All right, so we can begin. Welcome everyone to the next in our sessions entitled International Workshops and Webinars in Medical Education. I'd just like to welcome everyone that's joining and will be joining in soon. We will be recording the session. Today we have the great privilege of having Professor Judy McKim with us from Swansea University Medical Schools from Wales, United Kingdom. So to introduce her and to start the session, today's session on what does social accountability mean to health professionals and organizations, I'd like to invite our moderator, Mr. Hasnan Zafar Baloch of IMU Malaysia. So on behalf of IMI, Imamia Medics International and Sadiq International University, welcome everyone. Hopefully it's going to be a wonderful session. Thank you so much.
Yeah, thanks, Shifa. I think I will be moderating this session, and Prof. Judy, the floor is yours. Kindly introduce shortly, 2-3 minutes, and then you could start. And I will be picking up questions from the chat, and later on I will actually ask you at the later stage Q&A sessions. Okay, thanks.
Thank you very much for inviting me, everybody. Really pleased to be here with you all and talk about social accountability. My name's Judy McKim. My background is a nurse originally, but I've been in medical education for, I would say, about 35 years. So yes, I'm quite experienced. I do lots of writing, and I used to travel all around the world, but clearly I don't. But it's really good to meet all of you from different countries. So the topic that I've been asked to talk about today is about social accountability. And I think in light of the pandemic, this is probably more important than ever because we're seeing a lot more social inequalities coming to the foreground between countries and regions and within countries and different people, different populations because of the pandemic. So I think for health professionals, for organisations, it's important that we think about our social responsibilities. So what I'll talk about is the concept of social accountability, why it's important in healthcare and in health professions education. Give some examples of the activities undertaken at global, international, national and local levels, highlighting some work that I've been involved with both in Swansea and in New Zealand, and really think about how we scatter these activities and opportunities throughout our curriculum, both formally and informally. And students are very keen to be involved in different activities around social accountability. So I think the students are very eager, and I think from our perspective as educators, we need to think about, well, how do we put that into place? So just some sort of definitions really. Social responsibility is closely related to social accountability, and it's sometimes called civic responsibility. And really what this is all about is how individuals and organisations should act for the benefit of, or at least not cause harm to society at large. So it's all those things that we should be doing, just in our general life, not throwing litter on the ground, being kind to people, looking out for people who are less fortunate than ourselves. So that social responsibility is a wider concept, and social accountability as that we're talking about fits within that. So it's really useful to think about the social responsibility angle, and in this presentation I've given you some links to different things that if you're interested you can look more. So this is really just a sort of broad overview really. But the 4 pillars of social responsibility: organised and capable citizens groups. So this is about thinking around how do we involve the public and patients and communities in our curricula and in our activities. Okay. Having a responsive government, a government at all levels, and that might be the governance of an organisation. How do we respond to those things? How do we contribute to society and be socially responsible? It varies according to different cultures and contexts, so we need to be culturally and contextually appropriate. Our activities need to be right. I'll talk a little bit later on about, you know, it's not this notion of Western impinging on the East or impinging on low resource countries. That's the opposite of what we're talking about here. And also it's having access to information so that citizens, patients can make informed decisions. So they're the 4 pillars of social responsibility that sit alongside that idea of social accountability. So when we think about social accountability in healthcare, there's a lot of literature, it's been ongoing for quite some time now. And I quite like this definition by Fox about what does the evidence say. So in the context of healthcare, social accountability is a form of participatory citizen engagement in which citizens are recognised as service users. We might call them patients, but they're users of our services, health and social services, who are impacted by healthcare decisions and thereby can affect change in health policies, services and provider behaviour through their collective influence and action. So this concept of social accountability really goes outside the fact that, you know, we might all be experts in our particular specialties or in education, but it's actually pulling in the people who are going to be impacted by the healthcare decisions that we make, or the decisions that we make about what knowledge is important and what isn't. So it's that broader idea of involving people. We would involve students in decision making, perhaps because they're impacted, but also if we're thinking about teaching about long-term conditions, like for example diabetes or multiple sclerosis, let's talk to the service users about what they want. What do service users and carers want from dementia services? What do they want from end-of-life care? So actually actively involving people so that we can provide the care that's most appropriate. This has been very strong in a number of areas. I've mentioned end-of-life care, but also in mental health services, where service users have been involved. So what are the benefits then of social accountability in healthcare? So engaging citizens in planning and delivering care does lead to improved health outcomes. So some examples here, I mentioned dementia care, but child vaccination programs, actually working out why people might have perhaps vaccine hesitancy or getting access to vaccines. We've seen around the world, obviously smallpox has been eradicated, polio's on the edge. I know Pakistan has still got quite you know, some outbreaks of polio, but those child vaccination programs, the more that we work with communities, the more that we can understand how to best provide these things that will help them. It'll be really important when the coronavirus vaccine actually eventually does come, how that we work with communities to ensure uptake of the vaccine. Another one is maternal health, actually thinking about perhaps where that health support can be provided, the role of traditional birth attendants, etc. What also happens is it helps to address health systems inefficiencies, and it actually improves basic public health performance because you've got this better uptake and actually thinking about how to get care to different community groups, needs community groups to be involved. And it also helps us identify local solutions to health issues and problems. So not a one-size-fits-all approach. So something that might work in one country really well, actually that might not work in another country or another region because of the various issues, cultural contexts. It might be issues of access, it might be access to healthcare providers, it might be a cultural hesitance to engage with you know, sort of Western type health providers. So we need to just work about that because it does actually benefit. And this article was quite recent in Health Research Policy from Boydell and colleagues is really useful about thinking about how that happens. It's an interesting article. So Once we shift on to thinking about health professions education then, this is taken from the McGill website there. Social accountability has been defined by the WHO as the obligation of medical schools to direct their education, research and service activities towards addressing the priority health concerns of the community, region and or nation they have a mandate to serve. So this takes us broader than education. It's actually the research activities that we might prioritise or deprioritise, and it's the service activities that we engage with, how we do that. And if we think about the way that we structure our curriculum, for example, if a lot of service and healthcare is delivered in the community, actually if we have a curriculum that's very secondary care based or hospital care based, then that is not going to help address producing professionals who will work in those rural or remote or community-based settings. So it's quite a broad notion of how we might take this forward. But it's a balancing act, isn't it? We can't tip ourselves all the way to the needs of society. We can't be sort of everybody's now, you know, we can't restructure our curricula now to make them entirely public health orientated because the pandemic is on. We still have to prepare learners who can carry out a wide range of activities, healthcare activities, but also the teachers, the universities, preparing people that they can work in a range of settings. So we've always got to balance that up, how far we tip ourselves towards the service end and the community, and how far that we balance up actually, you know, and providing a good learning experience for our students. One of the key sort of initiatives that's been quite powerful, I think, and brought together a lot of the great and the good. They look as if they're all men apart from one there, but they're not. But it's called the Aspire Recognition of Excellence in Education. This is provided by AME, the Association of Medical Education in Europe. And it's got some of the founding fathers of social accountability in medical education. Bob Woolard is here, Charles Bolan, Henry Campos. I've got Trevor Gibbs here. You know, we've got all these. I want to scroll down, but it's a screenshot, so I can't. But really worth having a look. And what we've seen is the Aspire programme actually enables medical schools or health profession schools to be assessed against certain criteria to see if they meet these criteria in social accountability. And this is the Aspire network. It was built on the work of Towards Unity for Health. Some of you might have heard of that. That's really, you know, spreads across the world, that network. The Tunis Declaration on Social Accountability. But it's also brought the students in, the International Federation of Medical Students Associations. And I'll talk about this a little bit more later. But the criteria that schools can put themselves towards demonstrating are plans, including concepts and goals. So how far they go to addressing these social community needs, actions in education and research program activities, and then the sort of higher level of the evaluation bit is the impact. What are the positive effects of education, research and service? What do their graduates go on to do? What partnerships are there locally, regionally, internationally? And how do they commit to healthcare, health and health equity of their community, region and nation? So you might find that there are the strong Indigenous population, for example, in Canada, in the US, in New Zealand, Australia. You might find that they're working with Indigenous communities. It may be working in rural and remote communities. It may be working with disadvantaged communities in city and urban settings. So always it's thinking about what is this community about? How do we define it? And then how do the schools go towards it? So I've got a video here, hopefully it'll be fine on my Wi-Fi. This is Bob Woolard, who I mentioned, and Lawrence Sherman from AME, and they're talking about the Aspire programme. And I put this video in because it explains what it's all about a lot better than I can, really. So let's hope this is okay. I have tested it, but
Uh, I think you need to re-share again because we are still seeing your slide.
All right. Yes. Sorry. Yeah.
Or you
Yeah.
drag top
Yeah.
of it.
Wait a minute. Whoa.
No worries.
Okay. Is that okay?
Yes. Yeah. Could you play it? And just need to check whether sound. No, we could not hear the sound. I think when you click share screen,
Yeah.
Let me check. Is at bottom or at top? There is click checkbox the sound system sound.
Right. Okay. Whoops. I've gone back. Right. Wait a second. I've just stopped share. Let me do that again. Right.
Click
Okay.
share again.
Right. I need to get it back. Just 2
Yeah.
seconds.
Share. Click share and
Just wait a minute. I just need to get it back. I'm off. Go off. Right. Right. Okay. Right. Let me just sort myself out.
at the bottom there is a
Yeah.
checkbox.
Yes.
System sound.
Yes. Yeah. So my whole Zoom has just fallen apart slightly. Right. Share screen. Let's do that first.
System sound checkbox need to be ticked.
That's in the
bottom.
At the bottom, yeah. Right. Let me.
Yeah.
Okay. System sound. What am I looking at? Same as
tick it. Yeah.
On the video. I can't find it. I'll tell you what. Let's leave the video. Let's leave the video.
Okay.
I'll tell you what.
You could share. Or you could share me the link and I can play at my side.
Okay, let me find the link. Okay, sorry about this, everybody. Just a little technical glitch. It was working fine before, but
no, I mean video is played, but we could not hear the sound. I don't know. I could hear. How about others?
I could hear it. Let me pop it on. I'll get the link for you.
Yeah. Just copy the link in the chat.
Yeah, I'll send it in the chat. Yeah.
Sure.
Okay, I've just sent you the link. Yeah, because it's quite a good little video. So if you can do it, yeah, that'd be fine. Good teamwork.
No, it's okay. Let me make it full screen.
Okay.
Share the screen. Share computer sound. And may I know, could you see now the screen video? Yes, no?
Yes, video is okay, fine.
Yeah.
Who heads up one of the
sound clear?
Yes,
okay.
very good.
categories. And I think what's really important to hear is how you fit into this category. Not only that, but how you may reflect upon your own program. So Bob, why don't we talk about the category and also your definition of excellence to encourage more people to apply?
Okay. Well, in terms of the category, social accountability was defined back in the 90s by the World Health Organization as the responsibility, in fact, the accountability of a medical school at that time, and there are other health professional schools involved now, to taper and focus their research, educational, and service activities on the needs, the health priorities of their community, and they don't get to set those priorities. The priorities are set with a five-way partnership of, yes, the school, yes, the policymakers, yes, the people who manage the healthcare system, yes, the professions that practice, and finally, but most importantly, the communities themselves. They set the priorities, and social accountability is the fidelity of the schools to meeting them. And so, what we look at in terms of excellence, I prefer the definition that says more than doing the ordinary extraordinarily well. So it's that step beyond simply claiming that we mean well and we do what we can within our resources, but to actually get out, make the connections, and gather the evidence. And that's a key piece, is gathering the evidence of the impact, the positive impact that you have on the population you serve. And this year's winner, a wonderful example of that.
And what's really great about that, and the way you sort of frame that, is it's really about contextual. It's how is it in your own program. So it's not how do I compare with other winners from the last 200 years. It's how are we doing as far as the 5 criteria, but also how are we doing as a reflective exercise.
Yes, and you know, that's a very insightful and important comment, because excellence is not, as I say, just doing things really well. It's actually imagining and acting, but also the academic institution's commitment to saying not only do we mean well, but we actually have impact, and we can say our graduates are here where they're needed. Our graduates are doing the things that are needed. Our graduates are engaged not just in the practice of medicine, but in the whole system, as our speaker this morning talked about.
Right, you're preparing people to be effective and important community members.
Citizens.
Great word.
Yeah.
So would you encourage people to reach out to you directly to help and guide and mentor if they think they get it or they need a little help or advice?
Be more than happy to do that. Every medical school, every veterinary school, every dental school means well. But they may not think, well, are we excellent? Let's have a talk. You know, because, you know, the criteria are things we can talk about, and then people can decide. There's some really wonderful things out there, really wonderful institutions that are not applying, and I'd love them to talk to me.
Well, I think that's a great closing phrase.
Is it okay?
Thank you very much. That was great.
Nice.
Thank you.
Nice.
Okay, I'll go back to my sharing now. Thank you for rescuing me. Very good. That was great. So you've seen what Bob and Lawrence were talking about, and I would definitely encourage you to read some of their work, Bob Woolard and Charles Boland's work. Have a look at the Aspire, and if you think you're doing more than the, what does he say, doing more than the ordinary, doing the extraordinary, then, you know, have a look at that, and that's something that we might encourage different medical schools or health professions, veterinary schools to go for. So let's just go on to the next bit, really. So one of the things that's interesting about health is, and I think Bob referred to that in the video, is it's not just doing everyday things very well, it's doing different things. And some of the things that I think would have impact, and where universities and schools and health professions can make impact, is starting to think to be involved not just in tackling those immediate things right in front of them, but actually making what we call upstream interventions. Upstream interventions are larger interventions at a global policy or macro level. It's thinking about long term, what sort of university are we, what sort of school are we, looking at helping and informing citizens to demand this healthy society and to understand the best ways to get there. So the best way of describing an upstream intervention is if there's a very powerful river flowing down and there's a very weak bridge across it, which is very narrow and thin, it has no rails, and people keep falling off the bridge and drowning, you could do two things. You could make the bridge stronger, or you could put a dam upstream so the river wasn't as torrential and wasn't as dangerous. So an upstream intervention literally goes before to put something in place. And an example of that, things like vaccination programs are upstream interventions, because they actually tackle the thing before. We don't treat the polio or the smallpox or the measles or the mumps. We don't treat it. We go upstream and we put vaccinations so that it never happens in the first place. And for universities thinking about how to play a part in the local community, which a lot do, don't they? I think it is really important, and thinking where you can make some sort of differences. Oops. So one of the things that Bob Woolard talks about is thinking about the building relationships. So thinking about, here's the health system in the centre based on people's needs, but bringing together policymakers, health administrators, communities, academic institutions, our universities, and the health professionals there. So it's thinking about, if you're going to make positive change, everybody needs to work in partnership. And this is his partnership pentagram. We've just done a special issue of Medical Teacher, co-edited by Michelle McLean from Bond, Trevor Gibbs, president of AMI, and myself, on planetary health and education for sustainable healthcare. And this is part of that broader upstream ideas. So that, I think it's just come out actually, the special issue. So have a read of that, have a look at that. There's some really great ideas to embed things around planetary health in that special issue. I'm just going to give some examples now. So this is an example from Canada. This is Roger Strasser and his team. So Roger and his wife Sarah, they've just gone. They're Australian, but they've just gone to New Zealand, to Waikato, to set up a new health professions school there, rural. And this was Roger's big project, really. He went to work with the Northern Ontario School of Medicine, and this was really thinking about how to work with Indigenous and remote communities and work to attract the students from those previously disadvantaged communities into medicine, but also then to produce graduates who would stay in the region, who would stay in that massive near Arctic terrain of Northern Ontario. So really interesting one to look. This was in 2013, and it's definitely fulfilled its social accountability mandates. A lot of the students come from the region, 94%, 7% Aboriginal, 22% Francophone, French-speaking students, and 60% of the graduates have chosen family medicine practice, predominantly rural. So you can see that they're starting to have this longer-term impact in why they were established in the first place, to actually produce graduates who work in the region and stay, and who'll also do that. In a smaller way, Swansea University was set up really to meet the needs of Wales as a country, a nation, because it's relatively underdoctored, especially in the mid Wales and the rural areas. So our university, our medical school was set up for that as well. So in a smaller scale, this is a big project. So you can see that this happens all around the world, really, that we're looking at areas that are underdoctored or low in health professionals, and actually perhaps establishing schools to be there. So what goes hand in hand with this then, in many countries, is really the place of Indigenous knowledge and Indigenous peoples. And it's really important to plan and design education and healthcare where we're trying to work with the Indigenous population and their cultural beliefs and their needs. Tapping into the wisdom and knowledge about the importance of the land and the environment, traditional ways of caring and health practices. So, for example, in China, interesting that balance between Western medicine and traditional Chinese medicine. And we have integrated medicine that sits in the middle, where there's draws from both. And really thinking about incorporating this knowledge alongside Western science. And I worked in the Pacific with a medical school in Samoa in the Pacific, and that was really interesting. That medical school was established to work with the Pacifica people on the island to develop that doctors from Samoa for Samoa. And we see this happening all around the world, don't we? Where we're trying to actually tap into that knowledge. But I'm not sure how far we go. Certainly in the West, we don't go very far in really acknowledging traditional practices or the needs of Indigenous people. Certainly, you know, our curricula doesn't in Swansea, I know that. But working in New Zealand or Australia, I've seen this much more, in Canada with Roger. So we talked about rural and remote health with the Northern Ontario School of Medicine, and this is the Rural Health Information Hub, and there's loads of really good examples on this hub around how different research interventions are community based. So this example here, look, the wellness, health promotion, disease prevention, chronic disease self-management program. This is helping people with long-term or chronic conditions learn to manage their health, and that's led by the academic institutions and health professionals helping people learn how to manage. So these collaborations and interventions are where health professionals actually go out and work with communities or work with people with certain conditions to improve that, particularly important in rural and remote settings. And then, you know, there may not be doctors there, it may be other health professionals, you know, nurse practitioners or advanced practitioners, associate practitioners, physician's assistants. These, you know, community health officers might be the ones that do this. So one example that has taken off quite well in the UK, and this was a project that one of our graduate entry medicine students was involved with, and they've really taken the issue of social prescribing forward in Swansea. This enables healthcare professionals to refer people out of healthcare almost to local non-clinical services. It really recognised that people's health is determined by social, economic and environmental factors, addresses people's needs in a holistic way, and aims to support individuals to take greater control of their own health. A very common example of social prescribing is actually prescribing people a set of perhaps online CBT sessions for mental health or stress control, or for prescribing people gym membership, so that they can actually get fitter and healthier and take control of their own health. So social prescribing is really quite interesting and starting to take off. A limitation on this is often the way that funding happens. And if funding goes to healthcare separately from social care or from third sector or wherever, community services, it can be quite hard to move money from one place to the other. So you do need joined up systems, integrated services to be able to do this. And that's certainly in Wales and Scotland, that's we do have integrated health and social care, so we can actually do these things. So again, you've got to go upstream to think about the system and the funding before you can actually do these activities, otherwise it won't work. So sometimes the barriers aren't where you think they are. So here are some examples of student engagement, doing things in parks, community groups, working with religious or spiritual things. A lot of our students do volunteering. They work in primary schools, education and training, work with different communities. We have communities in Swansea around people who are rough sleeping, homeless people, drug addiction services, all sorts of things. And so students can get engaged if you put these opportunities in place for them in the formal or informal curriculum to actually get engaged in a lot of local community activities. This is a picture from our students' work and staff working with the University of the Gambia. So we have a partnership with the University of the Gambia between Swansea and the university and the health boards. So it's a health and a university partnership. So the university faculty and students, we have student exchange both ways. The Gambia students come to us, our students go to the Gambia. We have faculty go and do faculty development and work on those things. I've been a couple of times myself. We raise money, our students raise money. It's not us, it's the students. The Swansea students raise money to help provide equipment and things. We've got different grants that we've pulled in to do that, but it's also a health partnership. So our surgeons, particularly, we did a whole series of things around training advanced practice nurses to deal with cataracts, simple cataracts. So we had a whole it was called 2020 Vision. The project was about improving eye health in the Gambia, because that's a community issue. So these things can happen as partnerships between health services and the universities and the ones overseas as well. So that's been going for about nearly 20 years. It's a really strong, and it's supported by the Welsh Government as well through the Wales for Africa programme. So there's a formal governmental link. We have another one with China, with Swansea and China, and we have these links, and then following from those links we do lots of partnership projects, but they're always based around the needs of the Gambian community, not our needs. Okay, that's the point really. So I talked about upstream interventions, and these are things, again, we've got to think about then, well, what will happen downstream? So these are the benefits or costs that will result from our decisions that we made today. But the effects are often unanticipated, and it can set off, if you're not careful, unintended costs and consequences. So we had this a little bit with the Gambia, because the uptake was really big, and the project had at one stage had a danger of just a victim of its own success almost. And so we've got to think about, well, let's not start something off that we can't continue. So sustainability is really important. There's no point parachuting in, doing a project and that's not a collaborate and then going away. That's not a collaboration. That's doing a bit of consultancy almost. So we do have to think about what we're trying to do in the downstream, not just think about it as a one-time thing. So I think Bob said this in the video, social responsibility isn't a one-way overseas electives. It's not us sending our students out to go to, you know, the Pacific or Central America or whatever. It's not Western-centric colonialism. That is so not the point. It isn't the West telling the rest of the world what to do. It so isn't that. It's not simple activities that engage with the community either. So it's not things like just having, you know, workplace placements. That's not what it is. But it's actively working with communities to improve health and well-being on their terms. Okay, so it's the communities identifying the needs and us working as schools to try and improve health and well-being. And I suppose it reflects that mantra, doesn't it? You know, act local, think global. So we're always trying to think of that, the global health impacts. And this book we wrote about 6 or 7 years ago now about global health. The pandemic has thrust this into really sharp relief, hasn't it? That everything is interconnected, and we have a global citizen responsibility to everybody. So thinking about curriculum design and thinking about how to embed things in the formal curriculum. This is Swansea by the sea with our Swansea Bay here. Here's our university, the Singleton campus, all bright blue. Here's our students, our medical students again in the Gambia. And one of the things that we did with the Gambia project is that 20 students are funded to go to the Gambia as part of one of their work placements, their clinical placements. And so 20 students each time. So we always have a group of students going to the Gambia to work with the students and the faculty there. So it is a learning experience for them. They meet the curriculum outcomes, but that's embedding the partnership that we have into the curriculum. So it's sustainable. And that was a piece of work that we did when embedded it when I was the Dean at Swansea, and worked with Welsh Government to fund that. So we know that the funding is always there. So that's really important, because I felt if we were going to do it, it had to be sustainable, and therefore it has to be funded in this modern world. So we design our curriculum so that some students can go. I think another one is really important, is thinking about interprofessional learning. This is an example of the Pukawakawa project that I was involved with a team in New Zealand when I was there. And this was the Northland Regional Rural Programme. And again, this was a nice project where our students went into professional groups of pharmacists, nurses and medical students, and they went on placement to the Northland. and they actually had a structured curriculum there where they worked, and we worked with local communities so that they would learn about working in the far north of New Zealand. And here are some of our students. But it was a really good way of doing community-based interprofessional learning, so they were learning from, with and about one another, as well as working as a team in the community pharmacies and in the small hospitals there. So that was quite a nice project, and it's still ongoing. So the journey is really thinking future forward, isn't it? What we're trying to do is that we need to acknowledge and respect the past, to draw on the wisdom of traditional Indigenous peoples and where we've come from. But we've also got to work in the here and now on key issues and opportunities. We need to think about what's going on so that we can do that. But really, and I think I might have thought about this before the pandemic, but educate and train professionals for an uncertain future. We certainly, I think the present's a bit uncertain at the moment, but you know, we do have to train our professionals to be global citizens and to be aware. And one of the big things, as I mentioned before, is making our students and thinking about the impact of the climate emergency and thinking about planetary health, because it has a huge impact on health. Every 1 degree rise in global temperature sees global rice yields fall 10%, so you end up with huge malnutrition in some parts of the world. Air pollution kills 6.5 million. We've seen this with the wildfires, or the climate fires as they're calling them now, in rampaging around the US, that the air pollution, people with strokes, asthma, breathing difficulties is hugely increased. So if we don't tackle some of these and think about our part as global citizens in planetary health, our students are going to be dealing with severe health problems caused by this. And then this brings me on to talk about the other side of social accountability, which is what we might call environmental accountability, to ensure that we develop, promote and protect environmentally sustainable solutions to address health concerns of the community, region and nation they serve. That's quite nice. Again, this was written by David Pearce and Sarah Walpole and Steffi Barner before our medical teacher special issue, but they've written in this as well. And you know, we produce a lot of greenhouse gas emissions in healthcare, 4.4%. That was looking in 2019. And then all these different impacts on health, respiratory, cardiac problems, I've said poverty, starvation, previously managed infectious diseases such as TB, polio, measles. We've seen that as people's vaccination hasn't been uptake, dispossession of populations and increasing cancers due to carcinogenic pollutants, particularly in cities. So we need to think about, as professionals, thinking about our role in diplomacy, mitigation, advocacy and activism. How do we help our students become this? And the students are so interested. And so we're thinking about this from a leadership point of view, and we've called this, Michelle McLean and I, we've called this eco-ethical leadership. It's thinking about that inclusivity and social justice, being compassionate, taking responsibility and being accountable, thinking about when we need to advocate for groups, a moral duty to take care of the planet, see the world from a systems perspective, thinking about sustainability and regeneration and working collectively and collaboratively. And we think that these are the sort of leadership ways that we need to think about in our very interconnected world now to be truly socially accountable. And so, you know, let's embed these things. The General Medical Council's new outcomes for graduates, which is the undergraduate sort of standards, have now embedded education for sustainable healthcare into that. So looking at activities around climate change and impact on health, actions that reduce impact of healthcare. And this is really interesting that it's starting to be in standards and requirements from the regulators now. It means for schools that we have an obligation to make sure that we do this. So that's a good pressure on us, I think, in the UK. But the students are doing things themselves. So they're taking a global lead, especially IFMSA, tackling climate change, and demanding this is included in all health professions curricula. And there's some really good work from the MSA. They've done some fantastic work on climate and health. Their workbooks, loads of resources are really good. They're really taking the lead. It's going to impact on them more than us, isn't it? So we can see why. And then just to bring this sort of to a close, really, what we can do in the immediate future, thinking about the pandemic, and what some of the things that we've been doing. Students were graduating early to help in the health workforce. Our students have been prioritised as key health workers, so they're not seen as students, but part of the workforce. They've been looking after health workers' children, so the health workers could work, helping homeless, refugees and migrants, and also being involved in testing and tracing activities. So our students have been doing loads across the country, I think, working, and across the world. I've heard about it from different places. So there are things we can do in the here and now to get our students thinking about being part of this social responsibility. So just to bring this to a close, there are loads of resources around to help you embed activities in your programs. And the Aspire initiative is probably one of the strongest there, but the student resources are brilliant. The global pandemic has given us a real pause for thought and so emphasised the importance of our interconnectedness. But it's also given us more opportunities to think about how we can embed these social accountability activities in our programmes and, you know, think about global health and climate change and really think about things in a different way. So although the pandemic is hugely impactful in a negative way, I think also it's given us some pause for thought, and look how we're collaborating today and sharing practice and sharing ideas. So I think, you know, let's look at these opportunities as educators and think what we can do to actually work in this sphere of social accountability. So thank you very much. That's me done.
Thanks, Prof. Judy. I mean, it was a comprehensive talk about social responsibility and all that, our accountability. So there are a few questions, so let me read. First one is more relates context to Pakistan, but hopefully we'll be able to answer. How can we explain this concept, keeping in mind latest changes in the form of Pakistan Medical Council, and now there are many philanthropists in the council. Can we call it a step towards social accountability?
Okay, I'm not sure I'm the best person to talk about the changes about your the medical council actually. But I suppose, I mean, I'll just give one comment, and it may be that somebody, you know, from the region or from Pakistan can actually give us a bit more insight here. If there are philanthropists, I suppose it could be a step forward, but only if those philanthropists actually are moving towards, you know, this social accountability. I was reading in the newspaper today actually about one of the great philanthropists who set out, and he, in a secret way, to get rid of his £8 billion fortune, and he's just done it. He's just spent all his fortune on the, you know, the great and all these wonderful projects and things. And people like Bill Gates, Warren Buffett, you know, they do give back. But if they are philanthropists, then I suppose it could take a step forward. But it would have to be in, you know, under these sort of ideas of social accountability. I don't know if anybody else knows better than me.
maybe Prof. Shebi, maybe you want to add something?
Well, certainly things are changing in Pakistan as they are across the world. Medical education has definitely evolved over the last 20, 25, 30 years. A lot of rich people have gone into medical education. It's become more like a business than anything else. It's good to know in a way, because the quality improves with it. When there's money, obviously the quality improves, you get better equipment. I mean, I went to medical school, which is one of the founding schools of Pakistan, where we had very limited access to modern equipment. I still remember doing experiments in physiology in black coated drums or half-dead frogs and things. But things have changed. So I think it's a welcome sign to see in countries like Pakistan, India, Bangladesh, Nepal, everywhere. As a WHO consultant, I used to travel to different countries. I saw that in 90s already, after the publication of Tomorrow's Doctor, that famous paper, things had started to move forward. People were already thinking of problem-based learning, integrated teaching and things. So education has evolved. Social accountability is something which is relatively new. And this is a wonderful definition you've given. And I'd like to read more about Aspire and get involved with them. My answer to the question that was put forward by a Pakistani friend is that I think PMC or PMDC is a very authoritative thing. And not everything you can say is good about it. There's a lot of problems there. So it's more like a political thing, and less said the better. But the point I'm making is that to get more and more rich people involved in education, for example, at the moment, Prime Minister Imran Khan, who is a philanthropist, he has established 2 universities. Likewise, Al-Sadiq University is more like a philanthropic activity. Charity combined with investment. We're looking at 2 options. We're getting a lot of donations to establish physical university in Lahore, and there'll be a campus in Karachi also, but also investment opportunities. Now that brings in a lot of international collaboration. And that is my question to you, Judy, is how can we collaborate with Swansea University for global activity in northern areas of Pakistan, or India, or in Nepal, or Bangladesh, and Africa? Because Sadiq University is expanding to different countries. We have students coming from about 25 different countries. And also Medics International has work going on in 20 odd countries. So how can we collaborate with Swansea University and your program? Thank you.
Well, I think we can set some conversations up around collaboration, you know, but it's working out those schools that you'd like to collaborate with, isn't it? And that purpose of the collaboration, I think. Certainly, you know, our work with the Gambia has been, as I say, that was predated my coming to Swansea. But we do work with a lot of different countries. The university does as well, as all universities do, really. Mm-hmm. I was going to suggest that there's another question here that I think is really interesting in the chat from Shahid, and it says, what is your reflection on the ethics of recruiting underdeveloped countries' human resources, medical graduates, e.g. USA and many European countries practice of inducting underdeveloped countries' graduates with attractive offers that their own country can offer? Oh, I think this is such a huge issue, isn't it? You know, it happens right across the piece. You know, like the Philippines nurses, a lot are overproduced to emigrate. I think we're always going to have this inequality. I think the practice is morally not good, but you can see why. And I did a lot of projects with the World Bank and DFID and USAID and things particularly in Central Asia and former Soviet Union. You know, we'd be training, upskilling doctors or other health professionals, and a lot of them would then have those qualifications or the ability to and want to move. And, you know, you can't blame the individuals for wanting a better life for themselves and their families. But actually, you know, if you're not producing your own health professionals and you're relying on it, then I think, you know, the government does have to invest in that. But you know, it's a real challenge, I think, and that medical migration or health professions migration around, and I suppose this is why I've liked working on the schools that have been in country, producing their own graduates for their own country, like in the Pukawa project or in Samoa or whatever, because then you are really trying to keep people, or Roger's work in Northern Ontario, because then you're really training people who want to stay in the place. And there's a lot of research around showing that people from rural and remote communities, if their schools are there and they're trained there, they will stay or return there. So there's quite a lot of evidence about that, which is the other side of it, really. But yeah, it's a big problem, I know.
Yes, Prof. We have Dr. Omar Sharif. I think let me give him mic.
Not the
Dr. Omar,
famous
could you introduce
Sharif.
yourself?
Okay, thank you very much. I'm Omar. अंग्रेजी का एक मुहावरा है, someone's trash is someone's treasury. अम्मी इस घर की बुराई करते हैं लोग, मुझे कहते हैं अपने घर का डिजाइन दो.
Hello, Dr. Omar.
Sorry, there's an extra voice I hear. Okay, all right. Oh, my name is Omar. I'm from College of Nursing, teaching there, University of Slemani in Kurdistan, northern Iraq.
And my question for Professor Jody, after my thanks to her for that nice presentation, is for the social accountability in educational field. We already, as a College of Nursing in Kurdistan, involve students in our extracurriculum activities. But my question is about curriculum. Can we share or involve students in an abstract curriculum for the college? If yes, how can we develop that? And thank you.
Okay, so how do you involve the student? How do you put things formally into the curriculum? I think, and there's a number of ways of doing that. I suppose, you know, having that ethos around your students being citizens. You can have things like placements, that are with underserved communities. For example, we have placements with underperforming schools. We have placements with students, the roof sleepers and people who are homeless. We do work with refugees. And then I think it's having a really strong public health curriculum that actually takes this global health as part of its ethos. I used to work in health education and health promotion before I came to work in medical education, and that was, you know, very public health based. And I've worked at London School of Hygiene and Tropical Medicine on their public health doctorate, really trying to think of that broader aspect of health. It's not just about the person that presents in front of you with shortness of breath or whatever. It's actually around thinking of yourself as part of the system and working out how in all your activities you give back as well as you know, in a different way. So there's some specific examples. For example, embedding smoking cessation conversations with people that you encounter, or there's things that are broader public health about, you know, making sure people understand the role of the systems and lifestyle in health, as well as just treating the symptoms. But so I think placements have got a good role in getting students out, giving opportunities for students to actually work in other settings, such as rural settings, remote settings. I mean, a lot of the Australian schools were established on those very grounds, really, at the rural clinical schools, to actually be in the rural settings with students there. So I think there's quite a lot of things you can do with the curriculum. And I think it is that broader, you know, having that broader health curriculum for me is key, actually. And I think we'll see this as a consequence of the pandemic. I think we'll see curricula being much more strengthened and recognising that broader role of people in society. I hope so, because I think it's needed, really.
Yeah, we have Abdul Razak Sheikh. Let me allow him. Kindly introduce yourself and ask your question. Dr. Abdul Razak Sheikh.
There's a question in the Q&A,
yes,
isn't there?
Yeah, you can take that, please.
Do you want me to do that? Okay, so if people can see that. This is Azim Mirzazadeh, I think, talking about that thing about social accountability, primary healthcare, and a little bit anti-specialty, and also sending students and residents to rural areas. I think there's some of the common activities that people do, but I think it is much more than that. It's, as I said, it's working with different forms of healthcare. It's acknowledging different knowledges, different wisdoms. It's thinking about even in the specialties are absolutely needed at the pointed end of healthcare as a consequence of all the lifestyle factors and the things that have happened to people. So I think it's not anti-specialty. I think it's complementary to specialties, but it's also enabling students not to just see themselves as cardiovascular surgeons, but to actually think that they might have that broader role. And a cardiovascular surgeon works at the end of lifestyle factors and choices that people have made, or the cultures and the settings that they find themselves with. And I think, you know, that's the whole thing, isn't it? Whatever specialty you're in, actually having that broader way of thinking about the world doesn't mean that you can't give back. A lot of our clinicians do a lot of work overseas, you know, either voluntary or on projects, giving back to other settings, because a lot in Africa with the Wales for Africa funding and projects, but in many countries of the world that we do things, education training, as well as actually real healthcare. So I think it isn't just primary health, and it isn't just rural and remote, absolutely, but there's where some of the big work needs to be done, so that there's some big need there as well. And then Simon asks how to involve patients in social accountability settings. I think that's really involving patient and patient representative groups meaningfully in the curriculum. So, for example, one of the universities I've been involved with the General Medical Council in the UK, they have a really good patient community group, and they were involved in the design of the curriculum. They are on admissions panels to select students, so they're not patients per se, but they're representative groups. We have like a lot of schools, we have, for example, one of my neurology colleagues, she has a lunch and learn session where people with neurological conditions, living with those conditions, come in, and they provide lunch for the students and lunch for the patients, and they all converse, and they talk about living with these different you know, with these different conditions and how that impacts on their life. So things like that, you know, is involving patients in a much more meaningful way, rather than, you know, we do something to you. It's actually we're learning something from you, and this might improve the way that we care for you in future. So they're good examples of patients, I think.
Yeah, I think you have wonderfully answered the questions, and most of actually those friends who ask questions, they are very satisfied. So thanks for convincing them.
Good. I'm not aiming to convince them exactly.
I mean, they are satisfied with your answer. That's great.
Good.
So maybe we can take one more last question before we end this session. Anyone?
Dr. Saima has asked a question. Dr. Balot, Dr. Saima has asked the question.
He already answered.
How can we involve the patients in the accountability, social accountability? How can we involve the patient in the social accountability in medical school?
I think Prof. Judy already answered it. Or if you want to
yes,
add anything.
I did. I did think I'd answered it. Yes, actually. But yeah, it is about, and I think it's about meaningfully involving patients. So it's not things like having patients as OSCE patients. It's not that at all. It's completely the opposite. It's enabling your students to learn from different patient groups, to learn about how to improve their health care. So I'll give you another couple of examples. A lot of schools do something. We've got some projects. Our students do 3 projects, longitudinal projects throughout in the 4-year curriculum. The first one, they work with a family with a new baby, and they learn from the family and the new baby about how it feels to be a person with a new baby, and how that impacts on the family and the healthcare needs and all the rest of it. The second one is called Living with a Diagnosis, and this is the students work with the patients who's been recently diagnosed with a long-term or impactful condition. Sometimes it might be cancer diagnosis, but it could be anything. It could be a stroke or MS or whatever, but diabetes, epilepsy. And they work with that and learn from that patient about how that impacts on their life. Then they learn and to think about how, from the perspective of the patient and the family, and not just from, oh, well, let's treat it with this drug. So they're 2 examples. A lot of schools do things like that. And I think, again, it's not social accountability as such, but it's learning from patients in a different way. So I don't think it really fits under social accountability. For that, I think you need to be working with community groups in different communities, regionally or locally, on their health needs and how to improve that. So that would be through different projects and tapping into those. But, you know, there are ways of involving patients more meaningfully in the curriculum, I think.
Yeah, I think that's all.
I think in the chat, Fatima Zara is asking, are there any standard valid tool for assessment of social accountability? I would look at the ASPIRE criteria, because social accountability would be really hard to assess on an individual student. You know, isn't it? It's, oh, you're a really good citizen, you were all right, you were not very good. It's quite hard to do that. But I think if you look at the ASPIRE criteria for your school or your curriculum, you can start to think of how to go forward for that, really. Yeah.
Okay, that will actually, we will try to. Any other question? If no question, then I think I'll pass to Shifa. Ms. Shifa need to announce, I think, our next workshop on psychometric of assessment on 26. So just to add on, that is open to all participants, you know, so please do announce. And Ms. Shifa, could you close the session?
Sure. Thank you so much, Professor, for your time today. It was such a wonderful presentation and gave us a lot to think about in our respective fields. And we do hope to invite you again for some following sessions. So again, thank you everyone for participating, and just a reminder again about our workshop next week on September 26th at the same time, 11 GMT, on how to structure quality OBA and EMQs with Dr. Shahid Hassan of IMU as well. Okay, thank you so much, everyone.
Thank you for inviting me.